Doctors are saying, but they are not telling anything. They are telling use this gel, use this painkiller. They are changing the painkiller. How many painkillers we have to take? Okay. So this kind of situation, we should be very careful. Find it early. Okay. This is something is different. So what are the So what is the exact reason, we don't know, but there are some possible reasons. If the case comes, we can only speculate. We cannot exactly tell, oh, this is the reason, that is why the patient is getting that atypical or unusual pain. So you can only speculate. Today rain may come, okay, or may not come. So that is speculation, okay. So what is the reasons? So there are three kind of reasons we can see. One is the inter-implant teeth distance. Distance between the implant and distance between the implant and the natural tooth, there should be sufficient amount of bone. If it gets compromised, then it's similar to social distancing. No? There should be a distance between the implants or between the implant and the teeth. Why there should be sufficient implant between the tooth, between the implants or between the implant and the teeth? Okay, so this is a very important concept. If you understand this, your perspective about implantology will change. Okay. This is a jaw cross section, upper or lower, whatever it is. This is cortical bone, right? Buccal cortical, lingual cortical. This is buccal periosteum. This is lingual periosteum. So how the bone gets its blood supply? From periosteum, from this yellow color, from this periosteum, it is getting the blood supply. So it is providing nutrition to this part. Okay. Then what else? Uterus. Yes. Inferior alveolar vessel and its branches. See, if you draw the cross section here. So this is the inferior vessel. From the vessel, some small blood vessels will reach out and it will serve the intramedullary. So intramedullary is mainly with this thing, and from the periosteum and from the muscle attachment also. Myroid muscle attached is here. So mainly three aspects. One is from the periosteum, the bone is getting the supply. From here, from this pipe, it is running like this. So the blood is going like this. It is coming like this. From periosteum, it is coming like this. From the muscle and periosteum coming like this. This is how it gets its nutrition. Now imagine all the blood vessels in your mind. Now we are placing implant. Okay. 1, 2, 3, 4, 5, 6. Actually what you are doing is you are interfering with the blood supply now. Each stop your blood supply. Right? So the blood has to take a right turn, take a left turn and go like this. Right? It cannot go straight away this. There is full bone. Suddenly there are 6 metal pieces, 4 diameter or 4 diameter, they are standing in their way. Somehow the bone from the periosteum is not affected, the myroid muscle is not affected. Somehow here also some space is there, here also some space is there, buccally, lingually, it goes, it survives. Now we'll see another situation. We're placing a wider diameter implant like this. 8 implants, 10 implants. Now where is the implant is there, but where is the bone? How the blood will go? This part is left without any bone. See here it is very thin island here. How it will get blood supply? From here there is no way. Right? So this bone gets less blood supply. It starts to resolve. There is no nutrition. Okay, infection settles in. The patient is having pain. So you can imagine this situation in partial cases also. Most commonly, this mistake we will do. This is canine. This is canine. 4 incisors, 3 implants. Okay, 1, 2, 3. Okay. See, between the tooth and the implant there is less bone. Between the implant there is less bone, and between the implant and the buccal and lingual cortical plate is also less. So what you have to do is, another plan is, place a smaller diameter implant like this. This is enough. So implant is enough. Okay, little away from the adjacent tooth. Okay. This will be a correct plan. The CL dissipation, that is the problem we had. Okay. Same situation I am drawing. We place 2 implants very close to each other. Okay. 2 implants very close to each other. There is one incisor also here. That is why the patient is having pain. After we removed one implant, the pain got settled. But in the meantime, because of this closeness, that tooth went away. We did root canal, then still the patient was having pain. Then we have to remove the tooth and clip. How we did this mistake? If you see this view at the mid-root level or at the apical level, we could avoid this mistake. But we are not seeing this view, this axial view. We are not at all. This axial view. This axial view we are not at all seeing. What we are seeing is the panoramic view. Okay. So we are seeing the this is canine, this is canine. You will see you can place 3 implants. But actually if you see the axial section view here, you can only place 2 implants. If you see at the crown level clinically, you will feel that I can place 3 implants. But if you see the view at the axial section, you will settle at only 2 implants. So 2 things will misguide you. Clinically, sir, lot of space is there. 6 teeth missing. You can place 5 implants, 6 implants. But no, only 3 will be possible actually. If you see the panoramic view, what is happening is this bone, this is a curved bone. It stretches and it shows to you. It stretches and shows to you. Then we will feel by seeing the OPG 1, 1, 1, oh, okay, we can do 6 tooth extraction, 6 implant, upper maxilla, canine to canine, 6 implant. Even 5 implant maybe. You can place 6 implant, but all the implants will be touching each other, violating the social distancing rule. You may escape or you may end up in implant failure. So this view is a very good view to understand whether the implants are close to each other, whether we can place it correctly. This is not the panoramic view, this is the real 3D view, right? So whenever you see X-ray like this, see how close the tooth is with the implant. The left side is little bit close. So this bone is under trouble, especially if you use a wider diameter. During planning stage itself, you have to find the correct number of implant and select a correct diameter. See, if the bone is very wide, buccolingually wide, you can select a 4.2, nothing wrong in it. But if the bone itself is very small, buccolingually thin, don't put a 4.2 here. You got the point? So the more the buccolingually, the width is more, you can use a wider diameter. So this distance is also important. How much bone left buccally and lingually is important. How much bone is left between one implant and another implant. How much bone is left between the implant and the natural tooth. These three factors is all important. So planning stage, number of implants selection, selecting the diameter and location. Where you locate, don't go close to the natural tooth, don't go close to the adjacent implant. Okay. More bone, less implant. More bone, less implant should be our goal. So we used to think only from the implant standpoint, or 6 implants, 7 implants we have to select diametrically. But what about the remaining bone? How it will get its blood supply? See, from the true biological standpoint, if you point of view, you have to do the plan. Not just from your nose, you have to do these screws. That is why some of our old cases, when I am seeing this. Even recently one patient came for a checkup. I did 3, 4, 5, 6, lot of implants. Around 8, 10 implants close to each other, CLD situation. This kind of if you are not lucky, you may get bone loss in between implants, 1 or 2 implants. But this patient, no problem. But what will happen is, this is the buccolingual cross section. Okay, this is the implant you placed. But close to each other, lot of implants close to each other. So what is happening is the maxilla is getting less supply, or mandible is getting less supply. What is happening is the maxilla bone is going to atrophy because it is getting less blood supply. It is going to atrophy, means shrinking. So if you see the X-ray, it will be like this. Very thin bone covering the implants. That's like this. Actually, it shrinks. It shrinks. Okay. If you don't give food to somebody for 1 week, what will happen? They will shrink in the same way. Now she understands. So the maxilla and mandible, they shrink buccally. When you see the post-op X-ray of implant, only thin bone is left. I will be wondering how it is staying there. So selecting less number of implants, selecting the correct diameter, not always a big diameter, it works good. So these are the things to consider. And one more trouble is, see, this is canine. One patient this happened. We placed the implants very close here. very thin bone here. The patient didn't get immediate pain, but what has happened is, since this bone is very thin, this bone lost. There was a pocket and infection there. Continuously patient was, this is natural tooth also, no? The natural tooth. So patient was having constant bleeding here. Whatever we do, the wheel is a patient only, 4 years back. There is a pocket wheel here, but the implant is well integrated in this side. Mouthwash, curettage, laser, nothing works. It won't work because this bone is not getting the blood supply because it is very thin. This implant is stopping the blood supply. So at the time we don't know how to manage it. The patient was not satisfied repeatedly. The patient went somewhere. You know the patient to implant. Then later I thought we should have removed this implant. I was hesitating whether we could able to remove this implant. This is integrated on this side. It's a compressive implant. We should have done some osteotomy or open method. Somehow we should have removed and waited for some time, then again. So this is also one problem. Constantly the patient will have pain in this area, this crestal area, because especially this part is going to very less blood supply, the crestal. Okay. So this implants close to each other or implants close to teeth. The second is aseptic necrosis. It may become septic also, that is okay. Okay. Necrosis means the cells they are dying. Aseptic means there is no infection. Without infection, how a cell can die? Nutritions, blood supply, no blood supply, compression. So aseptic necrosis means many factors involved, as he told, less blood supply, then heat, overheating, compression, too much compression, then tight suture, necrosis of the bone. Okay. So overheating because of what?
Irrigation.
No irrigation or less irrigation. Then what is another reason for overheating? High speed drilling, using 1:1 handpiece. Okay, what we are using is 1:20, but some doctors they are using 1:1. There is an inbuilt risk is there. Then old drills, they are not going to cut, they will generate a heat, you have to give more pressure. Okay, so these are the reasons. And D1 bone is very cortical, that means there is less blood supply. You got the point? The more D1, you should not become happy. Okay, the bone is very cortical in nature, you will get good stability. No, that is not true. From drilling to implant placement to post-implant placement, there are a lot of troubles. Okay. And if you do compression in D1 bone, what will happen? The bone is already dense. How will you compress it? Okay. And if you did very less drilling and if you are selecting a very wider diameter implant, so that is going to too much compression to the there is nothing to compress, there is no place for compression. See, imagine this is a D3 bone, okay, there is lot of spaces. If you put the implant, this yellow color no bones, they will compress. In D1 bone it will be like this. If you do a 2 mm drill and if you put a 4 mm implant, how the bone will compress? There is nothing. Already there is less blood supply there. The more black spaces, the more blood supply. Okay. There is very less blood supply, almost no blood supply, very cortical. So already less blood supply. In the meantime, you are also pushing, trying to push. So surrounding the implant area, this blood cells, the bone cells will get too much compression. They will loss of blood supply. They will get necrosed. Once you remove the implant, surrounding the implant there will be a white sheet. Have you seen? Around the implant there will be a white layer sticking to it. The necrosed part comes along with the implant. Okay. Very thin mandible. Okay, very thin mandible. D1. These kind of cases will get into trouble. This kind of thing. So better to use a basal design, not compressive design. We don't want any kind of compression here. Select basal as much as possible. Select a smaller diameter. Even 3 mm is available. If necessary, you can place a 3 mm also. And next drill is sufficient drilling, sufficient osteotomy. Regularly we use a pilot drill and get 2 mm, 3 mm or 2 point, 2 mm, 2 mm parallel drill. Okay. Yeah. 2 mm parallel, 2 mm parallel pilot drill, 2 mm twist drill, then 3.6 mm basal you are placing. So in this kind of situation, use 2.8 parallel also. Some big drill, bigger than 2 mm, and place 3.6. Do not place straight away 2 and 3.6. You cannot insert it. Okay, you will actually crush and compression again will happen. So whenever the bone is dense, we should be very careful. We have to select the proper design, proper diameter, minimal height, and sufficient drilling. And doing implant dissection, we should be very careful. If you feel like it is getting tightened very soon, remove it, drill it again, then place it again. Otherwise, the implant will be there. On the day we were discussing on D1, D2 case, I was discussing this kind of cases. We should be careful, otherwise the implant may break. First implant break. Yeah? So we should be very careful. Because regularly we are doing D4, D3 cases. Suddenly if a D1 comes, our hands may lose the sensitivity and we try to do too much. It will break. Yeah? So the aseptic necrosis, what are the reasons? Overheating, too much compression,
less
blood supply, D1 bone. If all these things combine, then the patient will have pain. This kind of unusual pain, what is the classification? What is the types we discussed? One is aseptic necrosis. We remember that because it is the last one we discussed. What is the previous one? social distance, we will keep it as social distance. Okay, then inter-implant distance or inter-implant. So don't focus on the distance. Think about how is going to get the blood supply, the bone. Next is retrograde periimplantitis. Retrograde periimplantitis. In tooth you get periapical infection, periapical periodontitis. In the same way, the implant also may get infection around the apex. This is the implant. You will get radiolucency here. Crystally there won't be any problem, but only here. Or even if there is no obvious radiolucency is there, in the initial 2 weeks, no, you won't see any radiolucency, because in the very early stage, the bone loss, to reflect it in X-ray, it takes a lot of time. After 3 or 4 weeks, no, you may see the radiolucency, but within the 2 weeks time, you won't find anything. But the problem will be happening around the apex. The reason is, what are the reasons is, one is during surgery, some calculus or some tooth chips, it might have gone into the osteotomy. This is one reason. During surgery, contamination of the site. And another common reason is any adjacent tooth with RCT treated tooth. There may be some chronic infection sleeping there. This may affect here. Okay. So whenever there is root canal treated tooth adjacent, you should be very careful not to go closer. And another reason is, if it is a old RCT site or some periapical infection extraction site, the previous doctor who removed the root canal treated tooth or periapically infected tooth might have not cured it properly. So some granulation tissue remnants will be there, which is not resolved by the body, or some gataperchon, or some foreign materials is there. That is a latent infection. Okay. So it is sleeping, that line is sleeping. So the latent infection, it is going to reactivated by our surgical procedure and the implant. It is like and this also sometimes happens. The implant may be, there will be space here, but the implant will be closer to the apex here. It may be a root canal treated tooth or may not be a root canal treated tooth, but the nerves which is going inside the tooth apex, the blood vessels nerve, this may impinge over that, and that also will give pain on this tooth and this implant. Okay. So coming to the RPI. Okay. And one more reason for RPI is very D1 bone. Okay, lower anterior mandible. This is the mental foramen. From the mental foramen, you can see the incisive canal is running here. We used to think the interforamina area is without any nerves, without any canals, but that is not always. From the mental foramen, a branch of inferior alveolar nerve. What is the name of the branch? Incisive nerve. With its vessels, it is traveling till the midline, and they shake hands with the opposite side. mostly there won't be any trouble even if you go through it or impinge on it, no problem. But for some patient it will be very wide, it will be very obvious. So if you impinge on that, what will happen? There may be intramedullary bleeding, right? These vessels may bleed inside the bone and it may develop as a periapical infection and they may give pain. Or the nerve also may get disturbed and it may give pain again and again. So that is why observe the X-ray, CBCT for any nerves coming here. Most of the time there won't be any trouble, but rarely. Even one patient, the implant was very much front of the mental foramen. One patient you were discussing, it was in front of the mental foramen, but the patient was having pain. That may be because of the branch, incisive nerve branch. So preoperatively you have to check this. If the incisive nerve is very obvious, incisive canal is very obvious, make sure you select a shorter length and stop short of this one. Otherwise, no. So what is the first reason? Inter-implant and tooth distance. Aseptic necrosis. Then implant period, RTH. Okay. Then fourth is cortical perforation between 4 to 3 4 in the mandible. See, cortical perforation is good, it is okay for nasal cortical perforation, sinus floor, pterygoid cortical. In the mandible, lingual cortical in the 6, 7, 8 region, no issues. But in between premolar to premolar of mandible, you should not perforate the cortical bone. Whether it is buccal cortical or lingual cortical or lower border cortical. Even the lower border is also. So don't perforate the. See, this is the lower border cortical. If you perforate here, this is the axial section view. This is the lingual side. This is the tongue. If you perforate here, right, or in this way. This is the labial, this is the lingual. If you perforate here like this, or if you perforate lower border like this, what will happen is, there are two things will happen. If you perforate and if you place the implant, this implant will irritate this muscle and that will give pain. This is the myloid muscle, right? And there also myloid muscle comes. The patient will have pain, here, swallowing, swelling sublingually. And not only that, this bone, this bone, when you perforate the lingual cortical bone, it is not going to come out because it is very deep. It is going to be pushed here in the soft tissue. That small bony particles, they are in the lingual soft tissue. It acts as a foreign body now. So till it gets resorbed or getting encapsulated by the body, the patient will have no constant pain. After 2 weeks, 3 weeks, the pain will settle. But at till the time, we have seen such kind of patients. Imagine you have perforated here, but see, you have perforated here. Okay, but the implant is only till here. You have perforated here, but you have placed only till here. But you have perforated the lower border. You have perforated the lingual cortical, but not placed the implant. Even at the time, the patient will have, because you have perforated it and the bone debris has gone outside the bony envelope into the soft tissue. So if you prefer, the patient will have put it here and it will tell here. The patient was telling there is pain. So when we see the X-ray, we have perforated the okay. So depending upon where you have perforated, the patient will have pain on the sublingual area or in the lower border area, whatever it is. Okay. So in this kind of patients, actually better to see the bony debris. If it is not infected, okay, but many times if it gets infected, the patient will have swelling also, fever and all. If it is just there is no infection, it is only a aseptic inflammation, but the body will react. So better to give augmentin for 5 days, and as usual some LLLT, laser therapy. Yes, in 1 or 2 weeks it will settle actually. But the main thing is you have to avoid this complication. Whenever we are drilling in the lower anterior, you should be very aware about what is happening inside, where you feel the resistance. You have to keep the finger on the lingual aspect to guide. I am going where? I am going parallel to lingual or vocal or something. You are not keeping the finger on the lingual aspect, right? Straight away you are drilling. So we should keep the finger on the lingual aspect. So one is inter-implant distance, second one is aseptic necrosis, third one is RPI, fourth one is cortical perforation in the lower mandible. One more thing is the aseptic necrosis can turn into septic also. Okay. Once what has happened, it happened a lot of years ago. I used to go for a consultation in a nearby clinic. Everything went good, around 6 or 7 for 10 cases. We did no issues. The doctor was also happy. One day what has happened, for one lady we did a molar implant. After 3 days, 4 days, the doctor was telling the patient is having severe pain. After 1 week she called, I guess, because she was trying with some medications. She might have thought it is a normal post-implant pain. Actually for molar implant there won't be any pain. There won't be any pain. Even if the patient is not taking painkiller for more than 1 day, there won't be any pain. But if the pain is persisting after 4 days, 5 days, doctor was giving medication. So she couldn't able to handle the patient. Patient is asking a lot of questions. So the patient referred to our branch. Then we did we give some other medicines and multivitamin, laser biostimulation we did. Pain was not at all subsiding. Severe pain. So this kind of cases, in 2 weeks time, it is going to get mobile and it will come out, especially the molar ones. Okay, then I was thinking what went wrong. Then I thought, this is also one factor. This is 7, this is 6, okay, this is 5. They placed one implant, right? So during drilling, you see white debris coming out. If you do sufficient irrigation, all the white debris will come out. But if you don't do proper irrigation, that white bone debris which is removed from the bone. It will be sticking to the drill, no? But some will be inside the osteotomy also. They may be inside. With the bone debris, if you place a compressive implant, that old removed bone debris is getting stuck here, and that will create inflammation, pressure, pain, necrosis, finally implant failure. This is one thing. And what about contamination? So that setup was highly contaminated. That is not at all a sterile environment. Everything is open, from the forceps to the instruments. Everything is not very ideal scenario. So definitely the drills, everything is contaminated. So if infection is introduced into the osteotomy site, கொஞ்சம் செக் பண்ணி கொடுங்க அப்படியே பாருங்க. So along bone debris, some contamination is there. The contamination is tightly engaged between this implant and here. If it is a basal implant, is an extraction socket. No, extraction socket. Almost the extraction socket is open. Here the threads are very wide. Any infection is there, it is going to come out. There is an exit pathway is there for basal implant. But for compression, it is 100% tightly within the bone. There is no exit pathway of any contamination inside. That is why in BCS you can use it even in contaminated areas without any fear, because it is going to come out by the implant design. But here, whenever you are placing compression implant, asepsis is more important. Contamination we should take it. So I thought the contamination might be the reason. That is why maintaining a clean environment, using proper sterile drills. Apart from all other instruments, the drills are the most important thing. If the drill is having already debris from previous case, the stuff is not washed with the drills.
Okay. If we don't remove debris from one implant site or the implant site,
yes. So one implant site you are drilling, bone debris is coming, straight away you are jumping into next implant site. So that site might have infected, the other site might have not infected. So clean the debris during intraoperative also. Okay. So during cleaning the drills, you should be cleaning it very nicely actually. Preferably in a bath. Otherwise the old debris might be sticking there. The operating doctor might have not seen it, and straight away it goes cross contamination and infection. So look for the contamination issue.
Forceps, inner portion of the blade also.
No, lower end. But the problem is the lower anterior perforation. The bone debris might have gone outside the lower border. It will settle. How many days across now?
2 months.
Oh.
More than 2 months. 3-4 months. Long time.
And one more reason is implants. Okay. Take this only 2 implants. Take this only 2 implants. Okay. Only 2 implants are welding. You are taking one correctly, proper wire, and you are keeping it here. Okay. First you are doing welding here. While doing welding here, what you have to do? While doing welding here, in the next implant we have to keep our finger here. So after you remove the welding machine, this implant should be close to that implant. If you don't keep finger here, many times I am seeing you are not giving sufficient pressure here. You are not maintaining the pressure for 4 to 5 seconds. You have to If you remove this finger soon, this wire will go back a little bit off. Okay. So I am drawing another scenario. You are welded here, but the wire is like this, away from this implant. Now what will you do? You push this wire, actively you are pushing it and doing welding. Now what will this wire will do? It tries to go back to that position again. It will put a constant pressure to this implant. Or if this is a very stable implant, if this is a very less stable, this implant will try to push. So this will give constant. Okay. And one more reason for pain is here you are placing all compressive implant. Okay. All compressive implant, 4 implant, let us say. Distal mandible is very much dissolved. Here also distal mandible is very much dissolved. You are placing a basal here. Okay. Because their height is very less, you cannot place a compressive implant because the nerve is closer. This BCS implant should be in the lingual cortical bone. Okay, like this. It should be inside this lingual cortical bone. If it is straight, if the BCS is straight, that means it is not in the cortical bone. This is not correct. So this is a rigid implant. This is a elastic implant. You understand this, no? Compression implant is a rigid implant. This is a quite elastic implant. So this will move. So when you connect a BCS and basal and compressive, you should be very careful. Or if this BCS is not engaging the lingual cortex, it is only touching here, it won't get enough stability. It has to go into the lingual cortical, then only it will be stable. Otherwise there will be a movement here because it is rigid. Only this, they are not going to move. This will move. So the patient will have pain. We have 1 or 2 instances like this. Even yesterday that patient, left molar 3637 pain is, whenever a patient is biting, the 37 implant is like this. Okay, the 37 implant is only till here. It has not crossed it. So there may be some. Have you seen the CBCT? That implant? Yes. That is a 5.5 actually. Okay. So this thing also consider it. First one, canine area. This is after we remove that.
Another.
Okay. Patient for the left side, one rigid implant, but two elastic implant. This is compressive, this is good. This is, can you see it is not into the cortical. It's just touching the, it is not perforated. So it can move, right? You have to go beyond this lingual. We should have done that. Yes, that is the thing. The patient is having any trouble again and again, then you have to remove it and do. So this is another situation. You can see now. When you see from this panoramic view, it looks like here we can place 2 implants and we have placed 2 implants, but they are very close to each other in the axial section. This implant is become close to the tooth. If I have to avoid the tooth, then I should come close to this implant. Finally, this implant will be removed. Okay. So from the panoramic view, it looks okay. It is a correct plan to place 2 implants. Actually, you cannot place 2 implants. Yeah, you can see. See, the apex. This apex, the implant tip is resting on the apex, so it will be interfering with the periapical blood supply at all. So this is the X-rays sent by one doctor. Firstly, the patient was having constant pain in this. Already the patient was having one conventional implant, so he placed additional 2. What could be the reason, you can tell now? Close inter-implant distance. Okay. Even if it is in the panoramic view, it is very close. So definitely it will be very much close in the axial. Yeah, D1 bone. Maybe under drilling or overheating, bone debris locked inside. Okay, then yeah, aseptic bone necrosis. Yeah, they have welded it. Maybe the welding may be active, we don't know. So it's a salt speculation, we don't know the exact, we cannot tell the exact answers. But the possible reason is it is D1 bone, it's a possibility of aseptic necrosis, and maybe under drilling, too much compression during the implant placement, too much torque, and overheating, bone debris may be locked inside, whatever it is. And welding may be active. These are the possible reasons for this one. And he sent one more X-ray here. Molars missing, 6, 7, 8. Right? So this is the post-op X-ray. The patient was having. So what could be the reason here?
Patient having pain.
Pain here in this region. I don't know exactly which tooth. If you see here, the bone is very cortical. I once did an implant from my native place when patient came. That is also concerned. Doctor bring the patient. While placing implants, the maxilla was very much dense. Very rarely, especially in the premolar area, the bone will be similar to the D1 bone in the mandible. So while placing itself, I am feeling some kind of not so good feel. Very taut. I should have removed it, but it is too late. They have inserted it. You cannot remove it. After that, the patient was having constant pain for 1 month. Then later he sent a X-ray, IUP showing bone loss surrounding the implant. They removed the implant. So here also the cortical bone may be the reason, and one more reason may be the implants too close to each other. See, you may see the implants are very far away from each other. Don't believe the IOPA and panoramic view. Okay, if you see the clinical view, you can appreciate this. So imagine this area, how the bone will get the blood supply now. Almost 4 implants, they are standing in the way of blood supply. Okay.
And the process is also-
Yeah, here 2 implant may be enough or 3 is enough.
Process is fitting also.
Okay. Checking the occlusion. These 2 are the main factors: gum level, occlusion, and surgical factors. Only 1 or 2 cases, very rarely we get those. Getting outside.